Welcome and thank you for joining us for tonight's meeting, Intimacy and Cancer, a conversation beyond function for cancer management in general practice. This is in partnership with Sydney Local Health District. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us this evening. My name is Lauren Walker and I work across CESPN's cancer management and cancer screening and prevention portfolios, including the GPCanShare program. This assists general practice, community cancer services and specialist cancer services to work together in providing care for patients with cancer and improve their experiences of the healthcare system. I would now like to introduce our very first speaker of the evening, Kevin Ancog. Kevin is the prostate cancer specialist nurse at Royal Prince Alfred Hospital in Sydney. He has completed a Master of Advanced Nursing Practice and has extensive experience in, help me out here, Kevin, perioperative and prostate cancer care nursing. Thank you. His special interest and existing works in the area of prostate cancer care are focused on understanding the effects of continence and sexual pre- and rehabilitation programs on the outcomes of prostate cancer treatment. Kevin is the president of the Australia and New Zealand Urological Nurses Society and a board member of the Education Framework for Urological Nursing, a collaborative project between ANZ-UNS, British Association of Urological Nurses, and European Association of Urology Nurses. He is also a member of the New South Wales Agency for Clinical Innovation Urology Network, and contributes in the development and review of nursing toolkits. So I think we are very appreciative of you spending your time, whatever time is available for us this evening. Thank you, Kevin.
Thanks very much, Lauren, and thanks for having me tonight. My talk will focus on erectile dysfunction in relation to prostate cancer treatment, because that's my specialty. So I'm just going to focus on sort of like it's a precursor of sexual dysfunction, and also it can affect sexual intimacy as well. So because that's my specialty, I'm going to focus on that one too. And the overview of my presentation, first we're going to talk about the prostate cancer disease burden, just to understand how prostate cancer affects sexual dysfunction and erectile dysfunction. We're going to talk about the treatment side effects of prostate cancer, in particular the erectile dysfunction, and how we manage erectile dysfunction, especially in the primary care setting as well. So I've put up some slides on the principles of erectile dysfunction management and some primary care resources, and we'll talk about the take-home messages later. So just a disclaimer, my presentation contains some copyrighted material, and I didn't specifically get authorization from the copyright owner, but they are being used for this presentation in the principle of fair use. But if you want to use all these images for your own use, you may need to get specific permission from the owner. So just an overview about how prostate cancer affects, especially within Australia and specifically in New South Wales. In 2017, these figures are probably a little bit outdated because Rob Coast just released a new report. In New South Wales in 2017, there were around 32,927 cases of prostate cancer in the state. And that means that 1 in 5 males in New South Wales will probably be diagnosed with prostate cancer by the age of 85. And unfortunately, it led to some deaths as well in the state. And if you look at the trend as well, in 2022, it is predicted that there will be an additional 7,044 prostate cancer cases to be diagnosed, added to that figure. Within Sydney local health districts, that's where I work. I'm based in Royal Prince Alfred Hospital. In 2017, there were 381 cases that were treated within our hospital, without the local health district, and 158 of them went through RPA. Now, these figures might not reflect the real numbers, because within Sydney local health district, there are several private hospitals around as well. So these are just through the public system. So just an overview about what are the side effects of prostate cancer treatment. So we have 4 major treatment regimen that we use to treat prostate cancer. If they are localized, we either give them, radiation therapy, or we operate on them, remove the prostate. So that's the radical prostatectomy. And when they're advanced, we usually give them androgen deprivation therapy. So all those depot, the Zoladex, and those injections. And I didn't put up I just realized when I checked, I didn't put up the chemotherapy. So chemotherapy, we use that as a systemic treatment for prostate cancer, advanced prostate cancer, when they get out from the prostate gland. And if you can see, they are a little bit different with the profile of the side effects. But you can see in here that one of the common side effects among all those treatment is erectile dysfunction. And we're just going to step back a little bit and define what erectile dysfunction is. So it is defined as the inability to achieve or maintain a penile erection sufficient for satisfactory sexual performance. And that was coined by the National Institute of Health Consensus Conference in 1993. Pretty much it hasn't changed, it remains the same. So let's take a step back a little bit to try and understand how it happens. So erection, this is the normal physiology of erection. So when you have tactile stimulation through the organ, then you get the pudendal nerve that transmits signal to the brain, and the brain centers interprets it. Some of them go through the S2 and S4, and it goes to the pelvic nerve, back to the penis, the cavernous nerve to the penis, and that induces erection. In some ways as well, we get visual, auditory stimuli, olfactory, and imaginative stimuli that is processed in the brain center, and it goes through the same pathway and it ends up in the penis, and then it gives you erection. Now, for when that stimulation achieves a threshold, a specific threshold, then it will activate, the brain will interpret it again, send signals through the pudendal nerve, and goes back to all those organs, the penis again, and that's when ejaculation happens, or the orgasm, and you get ejaculation through the pudendal nerve. And then in effect for that one as well, it will induce detumescence, or the penis becomes soft along with that. So in a molecular level, you can see that, the cavernous nerves, there are 3 different fibers in there. So you get the adrenergic fiber, you get the cholinergic fiber, and the NANC, or the non-cholinergic fiber. So the cholinergic fiber releases the acetylcholine, which gets processed in the endothelial cells, and then in effect it will result to production of the endothelial NOS, or the nitric oxide synthase, which then gets converted into nitric oxide, whereas the cavernous nerve, the NANC fiber, directly releases the nitrous oxide. Now, this part is very important to understand how erection happens. When this nitrous oxide is produced, the guanylyl cyclase converts the GTP into a cyclic guanosine monophosphate, and then that will be used by the muscle cell to through the endoplasmic reticulum, and then in effect it will relax the muscles. So when you have a relaxation of the muscles, all the vasculature in there will also dilate, and then it will improve the blood flow in there. And when you look at the anatomy of the penis in here, so that's the flaccid state and that's the erect state. So when the blood vessels becomes dilated, they will improve the blood flow in there, and there are chambers inside the penis. There are the cavernous, the corpora cavernosum. This one, there are two, a pair, and they get engorged when it gets soaked with blood. And then in effect, that when it gets engorged, this tunica in here compresses all the veins, and it basically traps all the blood in there, and you get engorgement, and the penis becomes stiff, and that's how you get erection. Now, what happens during prostate cancer treatment? So radical prostatectomy, for example, it's pretty much simple. When they remove the prostate gland, this nerve actually originates from the spinal cord, and then it goes through the back of the prostate. So when they remove the prostate, most of the time by default, they remove they cut the nerve as well, because most of the time the cancer cells are very close to it, or sometimes sticks to the nerves as well. So you can see, just common logic that if you have a disruption in the cell signals there, it will not get to the penis. You get the erectile dysfunction. During radiation therapy, so the nerves get damaged through the heat of the radiation. But this process is a little bit slower, so you can find that patients with that radiation therapy, the erectile dysfunction happens a little bit late. And with the androgen deprivation therapy, we basically castrate them. They don't produce testosterone anymore. And when there's a deficiency in testosterone level in the body, one of the side effects is the decrease in libido. So if you don't have libido, those nerves are not activated, and then continuously you won't get erection. Now, the problem with that is if you don't have erection for a long time, this lining around here, so say for example, you don't have erection for a couple of months, the lining around those corpora cavernosa, they form scars, and scars are tough. So even if you feel that with blood, say for example, the nerves heal eventually, even if you feel that with blood, this lining in here, they don't expand, so they don't compress the veins. So in effect, the blood that goes inside will just go back to the circulation. And that becomes an additional problem with the erectile dysfunction. So it makes it more of a problem. Now, we know that erectile dysfunction can cause sexual dysfunction. Sexual dysfunction is multifactorial. It can be, some psychological as well. But that erectile dysfunction is just one manifestation of that. And it can also cause anxiety. And when a person becomes anxious, it gravitates to erectile dysfunction because your body will produce more norepinephrine, and that can cause constriction of the blood vessels, and more and more you get problems with erection, and then eventually it will low self-esteem, and all these problems will complicate. It can cause relationship problems in some cases, and of course infertility as well. All right, so what do we do with erectile dysfunction in our clinic? So we do penal rehabilitation, and it is a treatment or a therapy that helps men reach or regain an erection after prostate cancer treatment. So what do we do with the penile rehabilitation? So first, we use different devices and different medications as well to help treat the erection, to get the erection back. One of the first things that I provide with my patients is the vacuum erection device. So basically what it does is it creates suction in this chamber, and it forces the blood from the circulation to the penis. And when that happens, it stretches the penis. So if you put constrictive device in here at the bottom, it traps the blood in there and you get the erection. You can either use that for sexual intercourse, or mainly in our clinic, because most of the time they are able to spare some nerves. So later on, in 2 to 3 years' time, the erection will come back. But during that time, we don't want scar formation along that lining to form and then create more complex erectile dysfunction. So we want a good stretch there. We want good blood flow every day. So they use this every day. And these are medically approved devices as well. There are millions probably of products around, online or in sex shops, but I don't recommend them because they just break easily. So this one is sort of like the middle range, and it's also approved by the TGA. When patients have what we call a nerve sparing procedure, we can give them some phosphodiesterase 5 inhibitors and some intracavernosal injection as well. So when you go back to the molecular level for inducing the erection, you can see that during the conversion by the nitrous oxide of when the nitric oxide converts the guanylyl cyclase, when the guanylyl cyclase converts the GTP into cGMP, there are some small amount of phosphodiesterase circulating in our body, and it then turns the cyclic guanosine monophosphate to 5-GMP, and that inhibits the muscle relaxation. So what this medication does is it acts on the PDE5 so that this small amount of cGMP that is produced through the nitrous oxide, a little bit that is produced by the damaged nerves, they will be conserved, and eventually they can get erection. All right. So the injection works in a different pathway. So these are the prostaglandin and the papaverine as well. So they're contained in that one of the medications that we use. So you don't need the nerve fibers to act on, you don't need an intact nerve fiber to have erection using those injections, because they just get there straight. So we also have penile implants for those patients that don't respond to any of those treatments that we have, that we give them, either those tablets or injections. We give them the opportunity to think about having a surgery and having the penile implant, surgery. These are the penile implants got like 2 chambers in there, and there is another chamber that contains the saline that is implanted in the pelvic area, and there's a pump. So when you pump that, though, that fluid will be transported to the chamber, and in effect, it will make it engorge, and you get the erection. And you just press and hold that button in there, and it will transport return the fluid back from the chamber to the reservoir here. So bear in mind that even though these patients have nerve damage, that nerve is separate from the sensation that they use. They still have sensation, tactile sensation in there. So even if there's no intact nerve that makes them that is responsible for erection, they still have sensation in there. So if you put that chamber, the penile implant, then in most of the cases, for those ones that are non-responsive of the conservative treatment, they are very satisfied. And, the rate of satisfaction for people mostly is around 80 to 100%. That's because those patients are really, when you have patients who like penile implant, they really want it. So what are the principles of effective erectile dysfunction management? Number one would be appropriate counseling. And one of the challenges that we face during counseling is really how to tackle the topic itself. So what I do in my clinic is when I get to know them, they become more comfortable in opening up the topic to the clinician, and I put it as part of my routine assessment. So before they even have the any prostate cancer treatment, I would then discuss with them what are the side effects of the treatment, and then I will assess them what are their erectile status. So then it's not awkward, and I always tell them that the overview of what the consult is going to be. So when they first come to my clinic, I let them I assess them with the erectile dysfunction, so that you have the baseline, and then and then we manage the expectations, because there were some patients as well that come to my clinic, and when they, sorry, I just got lost. Yeah, so when they come to my clinic, they have so much expectation, because surgeons don't talk to them about the return for erection. They always get told that it will just return eventually, but in fact, it's not guaranteed, because if they're unable to spare the nerves, it will actually not come back. So it is very important that we talk to them prior to have that the realistic expectation, and it's important as well that we give them reassurance that you will be providing them with adequate support. So the second principle is prevention and timely intervention. So to prevent any further damage to the penis, and then make sure that they can still get back the erection, is we make sure that we put them in a penal rehabilitation plan straight away after the treatment. And of course, in cases where there are problems with even the sexual part of it, I do have some list of psychosexual therapists where I refer them to. And I find that support groups as well, which I think we do have a couple of prostate cancer support groups within Sydney Local Health District. We find that they're very helpful as well when they open up to the Ps, and the Ps will give them some strategies as well, how to overcome all these intimacy problems. And when we treat them, we treat the erectile dysfunction as well. We make sure that we treat them comprehensively. So there are different causes of erectile dysfunction. One of them is the medications, for example. So some antidepressants or psychiatric medications, or even antihistamines, when they use them regularly as part of their regular medications, in the background, that can actually cause the erectile dysfunction. So it's important to review them. And some of the medications that they regularly use could possibly be stopped if safe. And of course, lifestyle changes as well, because we know that tobacco smoking and alcohol use, even drug use, they can contribute to this problem. So if we try and control these, habits or these issues, then it will help with treating the erectile dysfunction as well. And of course, appropriate referral. So in the primary setting, there are a few things that we can do to help these men who are having problems with the erectile dysfunction. So there are some urologists, so they are the first go-to when treating this issue. And of course, GPs as well. Some of the GPs specializes in treating or managing erectile dysfunction. I know one that we usually refer our patients to. And of course, the specialist nurses, even though some specialist nurses like my colleagues don't necessarily treat erectile dysfunction straight away, they are very handy in navigating these patients to the right people. And the not-for-profit organizations, some of them offer some support in this area. So say, for example, PCFA, they provide resources, especially, and Cancer Council as well, they provide resources about how to manage this issue. I find for the LGBTQ AI plus community, ACON, or the AIDS Council of New South Wales, they have expanded so much now that they have lots of support. They have counselling services. They also have support groups that are focused in these issues. And we don't forget the psychosexual counselling, which is provided by psychologists that are specialists in this field. So if the Society of Australian Sexologists, they have lists of some practice available where you can refer your patients. So in summary, prostate cancer is a common disease among Australian men, and the treatment can be debilitating and will include erectile dysfunction. The erectile dysfunction after prostate cancer treatment is very manageable as long as we treat it urgently or timely. And you have prostate cancer specialist nurse, you have not-for-profit organizations, and even psychology services that are very important in managing this condition, especially for this cancer type. That's all.
Thank you very much, Kevin. Was there any questions? Did anyone want to come off mute or put a hand up and ask Kevin anything? I'm just double checking the chat and the Q&A. I was wondering, Kevin, you mentioned in detail about a lot of the psychosocial, the emotional support through the counselling, the support group referral, etc., for the patient. I was wondering if it's common to include or offer any sort of similar support for partners to then, not just for their own sort of emotional needs, but also for the coping and then support of the patient.
That's a very interesting question because, in the survey that was actually released just recently, there was published by Lai and colleagues. One of the, for the partners of prostate cancer patients, the second most common problem is actually the sexual dysfunction in the part as well, because we find that when these people, because they look after the partners, for example, that's got the cancer, right? When these people try and seek help, most of the time, they are not addressed, especially in the primary care. So there's a huge cry around that community. And it's really important that, it becomes part of the routine assessment, not just for the patient themselves, but also for the partner. So in those cases, what I do, because I'm not a sexologist, what I do is I refer these patients to those appropriate clinicians. And what I do as well in my clinic is especially the first time I see them, I would highly recommend to invite the partners or the wife or carers as well to come along with the appointment. And during that assessment, some of the issues can actually come up. And that's a good opportunity for us to, provide intervention right there and then.
Okay, thank you very much for that. George has just asked a question. Thanks, Kevin. How do you support patients who may be withdrawn or uncomfortable talking about sexual health?
Yeah, so I recently had one patient who had mental trauma from child abuse. So when he was a child, he was put into this boarding school, and apparently he was, abused, subject of abuse by one of the teachers or the priests. And so that actually triggered that mental trauma again during the conversation. So I learned so much from that upon reflection, that it is important that when you talk about this topic, very important to speak to the patient and make sure that they're comfortable talking about this, or are there any trauma that may be triggering the discomfort talking about this issue. So what I do is I also find that when you make it as a routine assessment, so you make it like you normalize the topic, it actually gives comfort to the patient to open up about these issues as well.
And that almost feeds somewhat into our next question around how can we start the conversation when a patient doesn't mention anything?
Yeah.
So from that GP practice nurse perspective.
Yeah. So one of the reasons why people don't open up is because they don't get asked. And I hear that a lot. I hear this a lot from my patients. I do ask them. I said, have you been asked about the the erectile dysfunction part? How is it going there? And they always tell me like, when I saw my urologist or my GP, they never talk about it, and I feel awkward starting the conversation. But then when they speak to me, I find that they're very comfortable, and they always thank me 100% of the time because I always pointed it out. So what I actually do is I say every 6 weeks after the treatment, I always have a standard question: how's your incontinence? And then the second one, how's your, the blood test levels? And the third one is always, how's your erection? And how's things going around there? And they know that it's just a routine question, but then it gives them the boost or the confidence to tell the clinician what's happening around there. And if there are issues like the erectile dysfunction, I always find a solution for them, put them in penile rehabilitation straight away.
Okay, thank you. And then this one may somewhat overlap as well, but in understanding the concept of penile rehabilitation, but when does intimacy enter the conversation? And that might be something that also comes up later on with both Shannon and Kate, but...
Yeah, do you want me to answer that one?
Yes, please.
Yeah, so the intimacy conversation usually happens when I do the first assessment. So when they come in, I always ask them, are you comfortable to have your partner or your wife? And they come to the clinic, and I always have the opportunity to give them a call and give them the brief about what's going to be tackled during the clinic appointment. So that will give them time to actually think about, the issues that they wanted to disclose. And I have one patient that, come in to the clinic with the wife, and I say, how's the erection, and how's are you sexually active currently? And they had different answer. So interesting. So the patient said, yeah, we always have sex every, every week. And then the wife said, no, we haven't done it for a very long time. And it just came to my sense that, some patients are actually not, they don't necessarily, sometimes they're not very honest. And when there's a partner in there, it actually helps, get the real situation, because sometimes when you say, when patient tells you that I don't have problems in there, and later on it becomes a real problem, they blame the clinician sometimes as well. So I always encourage them to bring the partner and do the routine assessment to get all the issues to surface. Yeah.
So including those intimacy issues as well as the more physical. Oh, well, thank you very much. I may have one more question. I'll just have a look. We have time for one more. Oh, good. We've got it. What about the elderly patient over 70 years in general practice?
Right. So for the patients that are over 70 years, they're the ones that always tell me, don't worry about that because, I'm not sexually active anymore. I don't have sex anymore. Or some people, they don't have, so some of those elderly patients, they don't have partners anymore. But it is important to know that's not the purpose to restore that part, the intimacy. And it is important to know as well that it's not an issue for them. But what I've always done is I've always been, very aggressive, so assertive in that sense in doing the penile rehabilitation, because erection is actually not just for sex. Erection, we do have erection every day to maintain the health of the penis and to maintain the size as well. And I did have in the past 3 patients that came back to me after 1 year of treatment, that they came back because the penis became really short, and it was a problem, just voiding, just passing urine because they're wet everywhere. So I always make it a point that penile rehabilitation is not just to restore your sex life, but to make sure that you maintain that functional side of it.
Okay. Thank you very, very much for your time and sharing your expertise with us tonight. I'll now move on to our second speaker of the evening. Professor Kate White has worked in clinical education and research areas, specialising in cancer and palliative care throughout her career. Her major research interests are in areas of supportive care in cancer and PAL care, psychosocial and quality of life issues in cancer, the translation of research evidence into clinical cancer nursing practice, and models of care with an emphasis in rural health. She has conducted a number of studies in these areas and serves on advisory boards, committees, and working groups of government and non-government organisations in cancer and PAL care. Kate participated in the development and implementation of clinical guidelines and is a member of the International Guideline Network. Kate has supervised over 20 research students to the successful completion of their degrees. In 2011, Kate was awarded the prestigious Churchill Fellowship to visit the Royal Marsden Hospital in London and the world's first nurse-led clinic for sexual dysfunction in cancer patients. She is currently working on adapting this model for the Australian context. Thank you, Kate.
Thanks very much for that lovely welcome. I think there's a lesson for me there is when you don't follow up when someone asks for your bio and they have to go digging for it, you end up with a much longer one than you would normally do. So thanks to Eleanor for that. Look, thank you very much for the opportunity to join you tonight. And it's a bit of a hard act to follow Kevin because he's incredibly knowledgeable and has really changed, really put a very patient-centered approach for prostate cancer patients here at Royal Prince Alfred. And I apologise if you think that I'm doing mood lighting. I thought I'd stay at work, and the lights are on a timer after 6 p.m. I've just discovered, and that just as I was asked to start, the lights went out. So apologies if that's a bit distracting for you all. In some ways, I feel a little bit hesitant to be talking to primary care providers, to GPs around this topic, because they are, GPs do so much work in that kind of broad sexual health area every day as part of their practice. And so this is really not a session of how to, but why and when it becomes a bit hard, I think. And I think that's what cancer does. I often refer to this quote, and this is just one of the sentences out of a series of columns that was done by a medical oncologist who treats predominantly breast cancer patients at the Memorial Sloan Kettering. And he wrote these columns after his wife was diagnosed with breast cancer. And what he was reflecting on here in this particular quote was that cancer impacts not just the individual who's diagnosed, but it has a very profound impact on all of those that are around that person. And it's a very graphic, sort of use of the English language there, a unwelcome house guest that upends lives and despotically redefines a person's sense of self in its own image. And it's the redefining that a person's sense of self that I think is something that can be very hard for us when we're trying to work with cancer patients and how it's impacting on them. I think Kevin may have touched on this, but I just wanted to reiterate the importance of sexuality, body image, and intimacy. It's fundamental to the way in which we share intimacy and experience physical closeness. So I think one of the things that can happen when we're talking about cancer diagnosis is there a perception that this isn't an important area. But both the WHO and just about every other sort of, peak body recognises that sexual function, sexual intimacy is integral to our quality of life. We often focus on the sexual function bit, but it is much more than that. And it's very much linked into how we perceive ourselves as an individual and our sense of sexuality, our sense of femininity or masculinity. And it's linked to our roles and relationships, not just with our partners, but also with families, work, and society. So when our body image and our ability to share intimacy and be physically close with those that are important to us starts to challenge us, our sense of who we are, both as an individual, but who we are within our relationships, can be greatly challenged. So is this a problem for cancer patients? One of the really good news stories, of course, is that we have a growing improvement in the survival rates from cancer. And we do have to remind ourselves there's not many illnesses that we can talk about cure. Heart disease, high blood pressure, diabetes, we're not curing those diseases, but we can cure cancer. And these figures are a little bit out of date now, but certainly over 60%. And I think one of the reports I saw recently was actually suggesting it's as high as 67% of cancer patients in Australia will survive more than 5 years. Not all of those will actually be long-term survivors, because even when we're unable to cure cancer, what we're doing is actually turning cancer into a chronic illness. And we're seeing more and more people living for longer durations with cancer, not just being cured of it. It's estimated that there's about 2% of the Australian population who are currently alive, living with a history of having been treated for cancer. And that means that they're people that are living with the consequences of that cancer treatment. And if you look at the tumour groups where we actually have that information, you can start to think about what the impact of those treatments might be. So what are some of the sort of long-term consequences of that treatment that those people are actually dealing with on a day-to-day basis? So do we know if there's a problem amongst our cancer population? Those of you who are in New South Wales will know that we have a New South Wales Health through the DHI does a range of inpatient and outpatient surveys on a regular basis. And this survey was done in the month of February on inpatients. Most of the time it's outpatients. And amongst those inpatients, approximately 40% of cancer patients identified that they weren't receiving enough information about possible changes in sexual activity. And I guess in some ways that's a little surprising, because you might think, well, if you're in hospital, you're pretty sick. You're either undergoing some initial treatment or your treatment is actually led to an admission, given that for solid tumours, about 90% of that treatment will happen as an outpatient. So if I'm in hospital and I'm thinking, hey, I don't have enough information about this, it really does highlight that this is something we should be talking about. Longitudinal studies that had been done in New South Wales by Alfred and her colleagues identified that sexual function and sexuality was the second highest unmet need. And more locally here within Sydney Local Health District, work that's been done by nurse practitioners in the head and neck nurse practitioners have identified that for individuals treated with head and neck cancer, in their prospective quality of life assessment they do with their patients, they found that at 12 months, most patients reported they returned to pre-treatment quality of life levels, with the exception of sexual function, which continued to deteriorate. If you look at the literature, we know there's a widespread problem. And I think what distresses me most about this whenever I do this, and I do quite a bit of work in this space, is that we continue to see these figures being reported in studies. I won't let on how many years I've worked in cancer, but I started out in gynae-oncology. And what I can tell you is that the figures aren't changing. And I think that's the real challenge that we have today. It's not that we don't know the causes of the problems. And it's not even that we don't always have interventions that we can put in place. It's that we're not putting the two things together. So when we see things like 90% of cancer patients will experience sexual dysfunction at some time during or after their treatment, and very high figures are related to specific areas. What's even perhaps more concerning is the areas where we have insufficient knowledge or information because no one's asking the question. If we look in the hematological malignancy setting, you'll find that most of the literature has actually focused on men, not women, post bone marrow transplant, for example. There's very limited work being done around interventions for graft versus host disease, which can be a very chronic condition that develops post-transplant, but particularly when it has an impact in the genitourinary area, particularly vaginal impact, that has a very profound impact. But trying to find a systematic approach or a unit that's delivering a systematic approach to identifying that early and implementing it is incredibly hard. I think the key message that I really want to get across today is, whilst the impact varies, and whilst the degree of importance may not be the same amongst all of the individuals who've been treated for cancer, we know that if it isn't addressed, it will worsen with time. And one of the real misnomers that is out there is that when patients start to report this, particularly post-surgery, to their surgeon, they're advised to give it time. We'll talk about it in 12 months if it's still a problem. And Kevin's given us a fantastic overview of how important the nerves are and what happens when we don't stimulate that. And that is absolutely true. If we're going to be intervening, we need to intervene early. And that's a really important thing. Now, that intervention may be some of the things that Kevin's outlined in the prostate cancer space, but it also may be quite simple things, or even just communication and providing information to address concerns that an individual and their partner may have. So what is some of the impact? Kevin and I are probably a good pair because I look after women more than men. But one of the things that we commonly hear is about decreased libido, and there's lots of reasons for that. There's lots of reasons outside of a cancer context that someone may experience either temporary or ongoing loss of libido. And we know that mental health concerns are a major factor in that place. But also there's a range of things that occur as we age, and a decline in testosterone levels in men, changes that occur in women due to menopause. All of those things can have an impact. If you add a life-threatening or a potentially life-threatening illness, or the need for ongoing treatment to that, then that's actually going to escalate it. But the minute we start interfering with hormones, then that's going to have an impact. If we look at women who are put on hormone suppression treatment as treatment for their breast cancer. One of the hardest things they deal with is actually the complete loss of any sense of wanting to be intimate with their partners. Now, that doesn't mean that can't happen, but it can be a significant change, and we need to work with those women about how to address that. A delay or difficulty in becoming aroused for both men and women. Pain with sexual intercourse, it's quite rare with men, but we see it with women. And most of the time when we see pain with women, pain with sexual intercourse in women, we really need to have an understanding of where they are from a menopause status, when they went through menopause in the context of their cancer diagnosis, whether we've pushed them into a premature menopause as part of our treatment, and the extent to which we've provided them with the appropriate information and resources to prevent them from getting significant vaginal dryness and potentially going on to develop vaginal atrophy. That's a very treatable situation, and it's so easy to prevent that from happening, but when people aren't getting the information and being supported to make those steps. Erectile dysfunction, I don't need to go. Trouble reaching orgasm is less common. We do see it, we know that it occurs as people age. It doesn't mean that people don't enjoy and experience pleasure, but they may not have as strong an orgasm as they had previously, or it may take longer to get there, or it may just not happen every time. And the other thing that's really important, of course, is the impact of any of these things on their relationships. But there's other things that can then have an impact. Their general well-being, previous sexual experiences, and one of the things that's really important, and I think often in primary care, GPs have a better understanding of how to assess and address this. But previous sexual experiences are incredibly important. And for me, one of the things working with women is I've always got in the back of my mind the potential that this woman may have experienced sexual trauma. The number of the incidence of women experiencing sexual trauma in our country is very high. So you can never assume that that may not be there. Not means I'm going to ask about it, by any means I'm not, but I am going to have a strategy prepared if it does come up, and I've done that already. Their relationship with their partner. One of the things that people sometimes think is that a diagnosis of cancer and treatment, particularly treatment that may change a woman or partner, either gender's body image significantly, may lead to the breakdown of their relationship. What all the studies show us is that a relationship that is strong at the outset of the diagnosis will remain strong. Relationships that were struggling and maybe had some fairly significant cracks in them before the diagnosis, then this is another crack, another thing that may actually widen the crack if there isn't an intervention, or it may just be the thing that pushes everyone to separate. Their overall personal health, we know that diabetes, high blood pressure, cardiovascular disease can have an impact on sexual function across the board. And it's not just the health of the individual, but it's the health of the partner. Sometimes when we're talking to women about maintaining their physical intimacy, they'll actually say to me, oh, that's okay, dear, my husband has diabetes and a couple of other things, and we haven't been able to do that for a while. That doesn't mean we don't talk more about it, but it does mean that we actually then clarify what is it as a couple they would like to be doing so that they can be physically intimate, even though they may not have sexual intercourse. There are important cultural things to think about, which is not about we don't bring the topic up, but we think about and we become informed about how do we actually, what isn't a culturally appropriate way to bring it up, and looking at things like family influences and media influences. But I think the thing that I've come to sort of learn is that it's the self-image that often gets impacted. And for us, we may not see a difference, partner may not see a difference, but for the individual who's gone through this treatment, they feel different. They've often lost confidence in their body, particularly if they've been diagnosed at screening, and they therefore have never been sick. You know, they were participating in a screening program. They may have been physically active, done all the right things to look after their body. And then they've gone into hospital as a well person, being told they've got a life-threatening illness. And that's a really challenging concept for many people, and it changes that sense of who they are. Partners are often in the clinical setting, I think, where we are in the acute setting, left out of the mix. Most partners receive information from the individual who's receiving the treatment or has the diagnosis. And we see this more with women than with men. And men, not always, but sometimes are very happy for their female partner or male partner to come along with them to appointments. And sometimes they're the ones that are asking all the questions. I was struck by one of the comments that Kevin made about asking his patient a question and being told, yes, they were sexually active, and then the wife saying, no, we're not. And I have a colleague who refers to families or partners or key carers as the truth tellers. And so sometimes it is important to find out from the truth tellers what's happening in a respectful way. Most of the time when I'm talking to partners, for them, it's they don't know how to navigate this space. They've not had to do this before. If they've had a very happy, successful, effective sexual relationship, it may have been something where they've never actually talked about it much. So when something comes along, they don't have the language to actually work out how do they raise the topic. Struggle for them is often about wanting to be supportive to their partners and a desire to demonstrate love, which normally would be done in a physical way, but at the same time recognizing that their partner may not be in a place where they're receptive to a physical interaction. There's a lot of fear that exists. Will they actually harm their partner or add to their pain? And sometimes spouses can feel neglected, or partners, or rejected, or may temporarily lose that connection or sense of connection, particularly if all the attention is around the individual who actually has the diagnosis. So one of the more common things I find is that when we're talking about, how cancer has an impact, when we're talking about relationships, it's very much the elephant in the room. It can also be the elephant in the room in medical consultations. It's the thing that everyone's tiptoeing around. The other thing that can happen in changes in couple intimacy, and I find it really important to highlight this and just explore this with couples, is that you shift from being a reciprocal partner lover to a patient carer role. And in a patient carer role, how do you, as someone's carer and being a patient to someone who's being a carer, how do you actually then start to think about physical intimacy, sexuality, and sexual encounters? It's sort of a fairly significant mind shift. And so often with couples, what I'm talking about is how do they go back to being a partner in a relationship like they were before this happens. The other thing, and I think it's really important because we often focus on sexual intercourse, but it's really about the intimacy. And there's a decreased intimacy due to a lack of or less frequent sexual encounters, but also a lack of and less mutual physical contacts, touching. If someone's going through radiotherapy, for example, and they may be experiencing significant fatigue, so they haven't done the sort of cuddling or going for a walk and holding hands, or they don't cuddle in bed in the way that they did. And that starts over time to become something that is a bit of a barrier to that they've got to work to overcome. When we, through our treatments, when we push someone, women into a premature menopause, they can experience significant night sweats and hot flushes or hot flashes. And so the thought of having their partner cuddle up to them in bed is the last thing they want. So you just don't even have that opportunity to spoon or cuddle. Similarly, for men, and it's not widely recognised, but when we put them on the hormone suppression treatments, they experience very fairly similar symptoms to menopausal symptoms. And the flushing and the loss of sleep and being hot can be really distressing for them. And please don't ever suggest to them that it's menopause symptoms, because that's quite distressing in that situation. And this is a quote from one of the studies that we've done, from one of the women that we talked about, with acknowledging how their relationship is altered because their partner is becoming their carer. As I said, partners fear they may be perceived to be insensitive if they're seeking to desire sexual intimacy. And when couples retreat sexually, touch may feel odd or different after a long sabbatical. And there's lots of reasons where this happens, not just in cancer. And so sex is often very low on the honey-do list after treatment. I have a honey-do list on the fridge, which is just all the chores I want my husband to do, all the things that I need him to fix. But I actually, with couples, talk about how do you get sex back on the honey-do list. So why does this remain a neglected area of care by healthcare professionals? And this is a really important question because we all know and we can anticipate the problems. And a number of studies have explored this. And I'm really sad to say that studies that still explore us came to the same conclusions. And the core themes are everybody recognises it's an important component of cancer care. It's integral to the holistic care. It's a legitimate concern for cancer patients to have. They are knowledgeable about the problems that they'll have related to sexuality and sexual function. But this knowledge is not operationalised. It doesn't translate into action. One of the major problems we have is that at the time of diagnosis and throughout the treatment, the core group of health professionals who fail to address this are the cancer team. Not every team has a Kevin. And even in areas like breast cancer, we still are finding for many women, none of the treatment team bring up the impact on sexuality, body image, or sexual function, and they wait for the patient to bring it up. So why is it so hard, and why is this not at the forefront of our mind, particularly when, as cancer specialists, we're actually giving this treatment and we know what its impact is going to be? Some of the reasons that have been proposed is that we're dealing with life-threatening illness. And so everyone at the time of diagnosis is focused on survival. What do we need to do? Partners are absolutely focused on do whatever we need to do so that I'm going to have a partner for all the time that I imagine. Everyone's focused on what the treatment is and getting it started. And yet when you think about it, for most solid cancers, there's actually no rush. You know, we have several weeks where we could actually be working with a couple, making sure they have the information, making sure that they're well informed about their treatment choices, particularly in solid cancer, when it's an early cancer that's been identified at screening. Less so in some of the hematological malignancies, obviously, where we do have to move rapidly. One of the problems that we have is we give information about the impact, but we give it at the time of diagnosis or early in the treatment phase, mixed in with a whole lot of other information. And so there's a real issue around information overload. And one of the challenges I think we have as cancer care providers, and particularly as nurses, is that we don't focus on education, we focus on the provision of information. Because if we were providing education, we would be actually assessing what someone's information needs, how they would like those needs to be met, and then ensuring that they actually have the information they need in a way that enables them to act on it, to become knowledgeable, to know what they need to do. Outside of when we do that initial information giving, there is often a failure to actually then go back and check in. There's a lack of follow-up exploration of impact on sexuality and sexual function. And there is a very strong perception, if there's a problem, the patient will raise it. But whose responsibility is it when we're talking about the cancer team here? So if you've referred a patient in, you've facilitated their diagnosis and they've come in and they're undergoing treatment, whose role is it to actually address this? This is something that's actually been looked at in a couple of studies, and these are the sorts of responses that they've got. It's someone else's job, it's not mine. Patients never ask about it, so we don't think it's really an issue. I don't know how to help, so it shouldn't be me, or I don't have the time. I don't agree with their lifestyle. They should be happy to be alive. that's actually the words that we use. Believe me, it's not what I'd be writing normally, but so that is, well, you know, yeah, it's that concept of, yep, I've caused that problem. That's a consequence of my treatment. But the good thing is that, you know, you're cured of your disease. Well, look at their age. They're too sick. They're too old. They're too young. Or the real risk that they often feel they have, that if I actually ask about this, it will offend them. And I always challenge particularly nurses about this, because we ask patients when they're in hospital about their bowels on a daily basis. If we can ask about that, we can ask about this, believe me. So what are the barriers that exist that we need to overcome? And some of these barriers exist wherever we are. So I'm, you know, where I've been talking now is about in the clinical setting, but they can exist in any area. And the major one, and I've got it in red, is the one that we hear just about all the time, is time. And I imagine that that is a fairly significant barrier for you in your roles as well. Privacy, hopefully that's less of an issue for you than it is for us. But certainly that is a barrier in the clinical environment, particularly as 90% of our solid cancer patients will receive their treatment as an outpatient, which means that we're often in open area. And as much as we like to think those curtains, if we pull them around, suddenly block all sound, they don't. And so these are really important conversations that need to be addressed with sensitivity and with privacy. And as I said, the lack of clarity in the team. There's a wonderful study that's been undertaken with a gynae oncology team in the UK, where they actually asked each of the team members whose responsibility it was. And everyone pointed to another member of the team. No one actually said it was theirs, but it did lead them to identify that it was actually everybody's responsibility. And that's kind of the message that I'd like to get across today. There are important professional barriers that have been identified. A lack of education preparation. Now that's a bit challenging on one level, because everyone's a very qualified health professional. They've met all of those requirements. One of the things that I was asked to do last year by a group of Sydney University students was would I be willing to provide them with a lecture on female sexual arousal, female sexual function. And they'd approached me to do that because it was not covered in their course content. And I'm still lobbying to get that in the course content. So if we're not giving the right level of education preparation, even as someone before they come out graduating from medicine or nursing or one of the allied health areas, then we've got a really long way to go, because where do they actually get that information post their graduation? A lack of skills and knowledge, and that can be around communication skills. And that's a very common thing that I hear from nurses when I'm educating them about this area is, but I don't have the words. I don't know what to say. I often, when I unpack that, what I find is that they do know what to say, but they're nervous about opening up a can of worms and they won't know how to respond to what comes next. That the knowledge of sexual function and its impact of cancer treatments is really important, but doesn't always have the depth it should have, particularly I would say amongst nurses and junior medical or trainee medical staff. But most importantly, what's not known is what are the simple practical steps that we could be putting in place to actually either intervene early or prevent something from becoming a problem. Nor do we have well-established referral networks. And then there are the personal barriers, lack of confidence, myths and misconceptions and assumptions, and we have them we're products of the society that we grew up in, we're products of our upbringing, and we will have the same misconceptions as anyone else. Discomfort, cultural and gender barriers, and embarrassment. What I'd like to do then, I'm just going to move really quickly, is to highlight a study that we've just completed working with GPs and colorectal cancer survivors. And one of the things that came through very clearly in that is that for cancer survivors, they saw the GP as their coordinator of care, but really saw that person as the person that they could talk to about this. And so it's really important to recognise that there is a sense of confidence that people have, your patients have, in raising this, but they find it difficult to find the conversation. And so I've just given here an example of how you might want to bring this up. So what's really important in moving forward then is we need to understand sexuality and the impact of cancer treatment, to become knowledgeable about treatments for sexual dysfunction. And we need to develop skills in taking a sexual assessment. Now, that's something that you're all probably very familiar with, but it is about the types of information that someone who's had a cancer treatment needs to have to address in practical ways the cause of discomfort. But the thing that I often say to people, one of the things that's most important is not that we're giving information, but we're actually using it as an opportunity to listen to patients, not just to what the problem is, but how it's impacting on them. And most importantly, what they would like to have done about it. Avoid making assumptions and encourage questions about sexuality. There's a website that I've linked through, one of the areas that I won't touch on, but it's about addressing myths and misconceptions. But there's a large program of work that's being undertaken by Jane Ussher around LGBTQI+ community. And there's a link there to some a video link that she's delivered about that work, which is incredibly informative and really useful. And I encourage you to have a look at that. I've also made available an article about primary care and sexual function after cancer. Thank you.
Thank you so very much, Kate. We really appreciate your time tonight, and with your permission, we will share those slides, some very interesting information on those. I note especially to the ways to approach those conversations, which I think are especially helpful. I will now introduce our third and final speaker for this evening. Shannon Brown is a senior social worker in the Sydney Local Health District. Currently, Shannyn is working in a secondment role as the GPCanShare supportive care social worker. This is an integrated project between CESPN and Sydney LHD. Prior to this, Shannyn was the UGI colorectal and pelvic mesh social worker at RPA Hospital. Shannyn has a wealth of experience facilitating patient intervention regarding intimacy, providing concrete communication skills to navigate a conversation that is rarely had. She has previously been a presenter at the Australian and New Zealand Hepatic, Pancreatic and Biliary Association Conference. Thank you. I'm sorry about that. And has an endeavouring interest in shared skills and intervention across the MDT to strengthen clinical confidence and improve patient experience. Thank you, Shannyn.
Thanks so much. So I guess to start off, I feel like Kevin and Kate have covered quite a lot of material, but what I really want to highlight, and I think Kate brought it up really wonderfully, is the fact that it's a responsibility across the multidisciplinary team. So I, from a social work perspective, definitely from the more psychosocial and relationship perspective, can speak about intimacy and bring that into conversations with patients where necessarily maybe when it's a particularly functional issue or medication related, that's not my area of expertise. So part of the role is also leaning on one another and finding where our areas are. I guess to start off, like all of us, I was not trained or exposed or resourced on how to support intimacy discussions in patient care, nor was I made aware of actually the significance of the importance of it. But like with most things in health, I had interactions with patients and the evidence was there. However, the only issue was that I felt out of my depth. And so I learned, and a lot of trial and error brings me to this point. I guess to start off, and I probably will try and just move through things quickly that I feel have been covered in the other presentations, is to start off that, you know, as we've highlighted along the way with the other speakers, like intimacy is a multitude of things. It is not just a sexual action. It is a vast exchange and a form of connection that someone has. Intimacy can occur with partners. Intimacy can occur in families. And it has that vast array, and we should be open and receptive to what that can be. Most importantly, we need to have a comprehension that it is something that is part of a person's quality of life, as equally as it is to have their financial needs met, their emotional needs met, to have intimacy needs met is part of making sure we're meeting those holistic picture. A person's sexual identity is made up from, so many countless things, including their cultural background, their social background, biological influences, and things like that. I guess moving on, I did want to highlight that, as we can see, when I went to define what intimacy was, it was literally this very brief, to have a state of a close and personal relationship or a romantic relationship with someone. So that gives me nothing. And I'm sure it gives you nothing to actually build off and see, how do we have a conversation with someone about it? I did find a little bit of a better quote in a quote maker along the way by quite a famous author. So I'll let you have a read of that. So I think just moving along, this is why it is difficult, because it is so ambiguous and is so open. Touching on what Kevin and Kate have done previously is that kind of understanding of what the domains of someone's sexual identity are. So we have the influences that can be biological and social and cultural. We can have the sense of identity, which is the biological sex, the sexual orientation, the gender identity. We have the behavior, which is the ideation, the activity, the experience. And from an emotional perspective, we have the self-esteem, the self-directed, and the interpersonal. So in all of those facets, there's triggers. There's also things that can be lost. There's the differences from our opinions. There's differences from our values. So this is all the aspects that can come into the conversations when we do approach patients. This is linking very nicely back into what Kate has already brought up, is who should initiate the discussion? And often we come to this point because we actually haven't had the discussion with ourselves in the MDT about who's going to initiate it in a patient's care. Actually, in health, I've come to find, even internally in my experience in multidisciplinary teams, as well as internally in social work departments, having these conversations about intimacy and how to bring them into our practice aren't necessarily had. So I think what we've done firstly is actually start tonight by saying, we all have a responsibility to bring that in. And also it is our responsibility as clinicians and healthcare workers, no matter what our role is, I feel we have a responsibility to bring it in. But in order to do that, I think we need to have a consciousness and understanding how to facilitate that discussion in firstly a very safe way for that patient. And that should always be the forefront of how we approach. The second part is coming at it from a very curiosity, and a caring way to better understand what the experience of that patient is, and to remain open and normalized and non-judgmental about how we approach it, although a patient's stance may be very different from our own values. So I guess moving on to my last very rhetorical question list that I have here is how to make yourself feel more comfortable. So I guess to start off, and I know that Kate has touched on it before. Sorry, I'm just the poll's just done something to my computer. Give me one moment. There we go. Is to start off about fears, assumptions, and discomfort. So my thing is, in discussions like this, we talk about our best practice and when we did it well and how we did it well. But when it comes to intimacy, I would say my greatest learning has come from when I did not do my best practice. And in that moment, I have held that moment and I have moved forward, and actually it really empowered me to improve my practice. So I'm going to share with you that I was supporting a patient who was, let's say, in their late 70s to early 80s, who'd been on a very protracted cancer journey and had a very long protracted admission with many complications over time. She'd had been married for over 55 years, and I was going in there to do an assessment that was a pretty standardized. I had a list of questions to ask, and I went in there to ask them, and sexuality and intimacy was one of those things. Now, it was funny, I had delivered this psychosocial assessment multiple times before, but when I got to the sexuality and intimacy question, I kind of very sheepishly brought up, I also just like to check in about, is sex and intimacy something that's still important for you? And I was so ready and prepared to kind of quickly skirt past it and get a no and move on to the next point. And I remember she stopped and said, yes, it's really important to me. It's really important to my husband and I. And in that moment, I had to stop and say, I was taken back, but it was only because of my own assumptions and my own discomfort that I had that reaction, because actually she was very open and receptive, and it was very important for her to talk about. And in that moment, when we started to talk about what was going on, we identified very early that we knew that wasn't a priority for her at that moment, because recovery from, the many procedures and discharge was the priority of her getting home. But I knew as her support clinician that she was going to go home and there would come a point that she would like to further speak about intimacy when she and her partner felt ready. She also felt empowered that she could ask her other professionals over time when she was recovering or following up with her specialist or GP that she could have those conversations. So I know it's not always great to say when we don't do good things, but I did just want to highlight that I've been there, I've done that. And actually I identified in myself that I was coming from quite an ageist perspective, that I had assumed because she was unwell and that she hadn't, that wouldn't be something important to her. Now, although that was not my best practice, I promise that has been a leading driver for me to never assume those things again and to have a very open conversation and bring it up even when I'm not sure of how the patient will receive it. Now, we've been speaking a little bit throughout the night, and I know you've had some questions before about how to start the conversation and where to facilitate it and what that may look like. So for me, I very much relied, and when I was doing my research early on, and found the Plisset model, which was created by sexologist Shannon in 1974. And so this is a really helpful tool for multidisciplinary people to bring up intimacy and sexual function in a way of understanding where you start and then meeting the patient where they're at. So we start at the top of the triangle, which all our patients would fall into, which is just to give patients permission to raise sexual issues. So for example, that might look like, I also just wanted to check in, a lot of other women who've had breast cancer have found that sometimes, their body image has changed and that can really affect how they see themselves and sometimes affect their relationships. Is that something that you've worried about? It's a really simple opener. And either that pathway, the patient will say, oh, actually, I have felt that. Or the patient may know that's not something that's impacting me. And if it's a no, that's normally a good indicator that that might be something that you can move on from. It doesn't mean you end it sharply. You can say, okay, well, in future, if that does come up, please feel free to, ask me. I might also just check in about it as you recover to see if that changes. So that is where the permission lies. The next step down is the limited information. So it's giving like a broad concept of maybe what the functional changes they may find will be. It could be a broader understanding of, the issues. So I will come into case studies later and I'll apply this model. I just wanted to give you a rough understanding. So it's more generalized advice about what that may be that, cohort or that particular cancer outcomes or treatment may impact. Now, coming down a bit further, you'll find that if that continues to be a need of the patient, you'll fall into the specific suggestions, which is making one based on the presenting problems that the patient has identified. So in my patient that I'm coming to the case study, they have a colostomy bag, and it is the appearance of the colostomy bag that is their issue that they feel uncomfortable about. So I would be able to provide suggestions about maybe, have you thought about getting a cover? I could resource them with information sheets from the colostomy website. I can also recommend for some of our younger patients that have, colostomies or stomas or things like that, there's actually a really wonderful amount of youth YouTubers that have done videos talking about these things. So it's about providing specific information that is relevant to the problems presenting of the patient. Finally, moving down is the intensive therapy, which is, the very minority of patients where you bring this topic up may come. So that's when you would refer on to intensive therapies or you would refer on to specialist medical services in order to better support that patient. Now, this Plisset model, I say, is not a one-off intervention. It may be something that the patient fluctuates in your practice with or in your presentation. In your relationship with over the span of time. And it's something that should be continued to be touched upon. Okay, so moving on. Sorry, I'm just keeping track of the time not to keep you. So I'm going to quickly run through 2 case examples because I think that would be really helpful. So just to start off, I'd love you to meet Martin. Martin is a 43-year-old man who has had a recent diagnosis of colorectal cancer, resulting in emergency Hartmann's operation and a formation of a colostomy. He's been married for 9 years and has 1 child, and he's a farmer on a remote property. So I've actually supported many patients that have many inherent qualities of Martin. And so I guess the first thing is, how do I start the conversation? So I guess the first point is like, how many times have I seen Martin and what's our professional relationship or rapport like? So let's say I've met Martin once before this discussion. I went and spoke to him about really practical things. So when I saw him, I acknowledged he was a long way from home. I acknowledged he had an unexpected procedure and touched about adjustment. I sorted out his IPTAS form so his wife could come down and stay. And that was kind of the relationship that we'd had. And we hadn't necessarily touched on any deep emotional adjustment, nor in regards to intimacy. So my next time with Martin, I went into the room and said, you know, how do I introduce the topic of intimacy in my head? How am I going to bring it up and touch base? And I did it for all my patients often that did have a colostomy, because it was a significant body change and it did have an impact on their intimacy. And that was shown in some of Kate's data. So how I'd introduce would be, many other patients are often worried about how their partner will feel about and what their reaction may be. Is this something you've thought about? So that may have not been my first question, but that's a really significant question to ask. Other questions I may ask is intimacy and sex important to you? The patient may say, no, it's not. Or the patient may actually say, yes, it's really important to me. And so I would then say, so sex and intimacy means something different to everyone. What does it look like to you? And how is it important as a part of your quality of life? So maybe aside from Martin, say if we talk about maybe one of Kevin's patients, if you have a gentleman who says that he only perceives sex as a penetrative action and that's something that he's not able to do after his procedure, it could be assumed that his adjustment may be a lot more difficult if his assumption and his experience of intimacy as sex is seen within that framework. And that's part of the reason we ask these questions. The next thing you do is, how are you feeling about your body? How do you feel when you look in the mirror? And often you'll find is that people said, I can't look at myself in the mirror. I look at my colostomy and it's disgusting and it's gross. And that's the reaction they have. So before we delve too deep into discussing the intimacy in the partner, it's actually about that self-body image and that esteem that we really need to be delving into and talking a little bit more about. I think the hard part with stomas, and I think we all as clinicians come up with different ways, is that I used to describe having a stoma is almost going through like a different puberty in your body. Your body's gone through a change that you're not necessarily in control of. You're not used to the feelings, the sensations, you're not used to the actions. You've lost that kind of connection with it, and they have over time, you will be able to build that. But for this period, that's the kind of experience that you're sitting in. And that's just one of the things that I lean on when I'm supporting colorectal patients. The next thing is delving into that relation. Do you and your wife talk about sex or intimacy? Do you feel able to talk to her about it? Some will say, no, we don't talk about it. She wouldn't like to. That's not a boundary we cross. And that really gives you a good understanding of where they're at that moment. And so once the patient has identified their worries, so say Martin's identified worries that I'm really worried that my wife will see my colostomy and it will be gross, or I'm worried that my colostomy will leak. So my thing would be reflecting with the patients. So your main worry at the moment is the colostomy and how it looks, and worrying about it if it will leak. Okay, so that gives me two concrete things that the patient themselves has identified that we could work on. So it could be two things. So from a leak perspective, that might mean that I speak to the stomal therapist and we can have a discussion, and they can go and discuss different options of how, to better support it, to better support the stoma care. Other things could be from the colostomy is getting a bag that could cover, like a cover for it. You can get great ones off Etsy, and you can get Batman ones and things like that. And then I guess just moving forward, just because I'm again mindful of time, is that, having that permission to also share some other things that may support that. So would you like me to share some things that may support those worries? So it's always checking in about that permission. And I think what we need to understand, it is okay at any time for the patient to say, I'm not comfortable anymore talking further about this. And it doesn't mean that you've done a bad job or you said the wrong thing. It just means that that patient at that time hit that limit. And actually the greatest thing you can do is respect that boundary, because that will then create an opportunity and a trust later on for the patient to be able to A, talk about it again, or feel comfortable that they can set those boundaries in their care. Okay, finally, I'll move to my quick last case study. This is Sandra. She is a 60-year-old female diagnosed with ovarian cancer 5 years ago and has surgery and chemo. She's divorced, and her relationship status to myself is unknown. I know that she lives alone, and this is, say, the second appointment say, to a practice, I'm giving a bit of a round second practice and it's a long appointment. So again, touching point that I know in a 15-minute consultation, there is not going to be an opportunity to bring up these discussions because time is needed. But we may have the opportunity here when there's a longer appointment available. So again, starting with that permission and that opening and normalizing that many other women who've been on a similar journey to yourself have had some worries about intimacy. Is this something you've thought about? And she may say yes. And what I would touch base, is that a current or a past worry? And she could say, actually, it's a bit of a past worry. It's part of the reason that my relationship ended and I was divorced. We lost that sense of intimacy. And so something that's, really uncertain about. And so what I'd say, so you've been unsure and fearful if you'd be able to be intimate again. And then you can touch base and say, have you tried? What happened? How did you feel? And so all of these are very open questions for the patient to touch base and say, actually, this is where I was at and this is what was happening. Another thing to touch base about is not assuming because someone doesn't have a husband or a partner that they're not sexually active or want to be intimate with another one. So asking, do you have a partner? Are you interested in having a sexual partner? Is that something that's important to you at the moment? Is that something that may be important to you in the future? And I've had patients say, I've had the 40-year-old man say, no, that's not something I'm interested in anymore. I've had, multitude of people across the lifespan have very different reactions to that. And I think it's really important to have that open discussion that, being married doesn't insinuate intimacy. Being without a partner doesn't mean that you also don't want to participate in intimacy. I guess coming on from that is like, did you want to talk more about it now, or would you prefer to talk about it another time? Sometimes that is a really great question in that moment to ask. And it's not about shutting down that discussion, but it's also just saying, this is something we can talk about it. I brought it up. It might have been a bit shocking. You may have not been prepared to talk about it, but how about we can do that in future if that's the case? These are all the insinuations that we do in the context of how we communicate. So let's just say that Sandra said, actually, I'd prefer to talk about it another time. And I said, okay, next time, would you like me to bring it up, or would you prefer to bring it up when you feel comfortable? And she said, actually, I'll give it some thought. Maybe let me bring it up next time. And I said, okay, well, when it gets to that point, how about you booking for another long appointment and we can talk about it then? So those are all the things about how we communicate. And I hope I'm sharing some of our skills because I think we all practice really differently, especially what our discipline backgrounds are. I'm a particularly very conversational person when I practice, but you may not come from that same background. So please feel free to adapt and adjust these to what your particular practice and intervention styles are. And finally, and I think Kate touched on it beautifully. So I feel like Kate and Kevin have segmented and just segued beautifully into my presentation. So I'm very appreciative of it. Is the understanding of the transition from partner to carer and then transition from carer back to partner and those opportunities. And I guess the first thing when we talk about caring is that intimacy in sexual relationship is lost and grieved during the process of transitioning from partner to carer. And that goes for both the partner to the carer and the person that is being cared for and is no longer the partner. I think a really huge thing to acknowledge, and sometimes we touch base on, is about the dignity and care in that sense of touch. So, those incidental moments of intimacy that used to be in the relationship, which may have been, cuddling, hugging, putting your arm around each other as you're cooking away or something like that, will shift to moments in care. And we should not have assumptions that a person who is being cared for may feel, would automatically feel comfortable for their partner to be providing those care actions. So, touching base about, would you feel comfortable if someone was to need to change your pads? Would you feel comfortable to change the pads of your partner? Would you feel comfortable your partner supporting your bathing? Is your partner comfortable supporting your bathing? And it's often flicking backwards and forwards into those, very consensual things about touch. And I think we don't talk about it when it comes to a carer relationship. I guess the other thing that comes with that is that when that loss of intimacy occurs, it's also part of that loss of relationship, and there can be a real dual grieving process and differing emotions. The person who is being cared for may feel like a burden, or that they're making their partner miss out on things. And I know when I was outside of this cancer space, when I was working in the pelvic mesh complications with patients, working with patients with pelvic mesh complication, that was often something that came up, was this feeling that they had taken something away from their partner. I guess moving outside of that is that transition from carer to partner. So in my current role in the palliative care space, it is about, I guess, focusing on, there comes a point at end of life where actually it can be really important for a carer to step out of the carer role and have external supports come in to meet the care needs, so that that person can return to being the partner and return to having those moments of touch and that energy to have that sense of intimacy outside having to be the sole carer. So that could be like, you know, if a patient was to attend the palliative care unit, it means that their partner could be sitting there holding their hand. They could brush their hair, they could get them some water, and focusing on those very intimate actions outside of those very cumbersome carer tasks. And I think it's really important, and I have these discussions at that time with carers and families and things like that, that is okay to want to step back into being a partner. We have supports to support the care of the person and allow you in that moment to go back to that relationship. And so, you know, having those discussions has been a really eye-opening way of seeing how patients and families react to those things. And I've actually had a really positive feedback, allowing them to have those opportunities to go back to feeling like they have that relationship with their partner, and feeling like it was okay to say, actually, I'd like someone else to be providing those carer tasks, and I would like to go back to being their husband or their wife or their partner and holding their hand and having that very special time with them. I think I've actually, the other thing I'll touch on before we go, sorry, I'm mindful of time, I'm keeping you a little bit longer, is that there is, from a counselling perspective, it's more of a private access, as we know, to access supports around intimacy and sexual counselling and things like that. I have listed some services, and Kevin said that he had his private list as well. But if you're speaking to someone who has very low socioeconomic, means, and that's not something they're able to access, it is a really limited pathway. So it's really important for us to be having those conversations supplementary, so it doesn't get to an acute point, and maybe there are issues earlier on in the path that we would be able to address. The other thing is there is a multitude of resources which are listed at the bottom, of different booklets that may be appropriate. The Cancer Council has a great one, Palliative Care and Dementia has one. There's all different ones, different associations, even the Colostomy Association has things. And if there's very specific things, there's even YouTube and things like that. And for my younger patients, that's very significant. I can see Lauren pop up. I'm done, Lauren.
No pressure, just in preparation. Thank you, Shannon.
No.
Was there any questions? Again, I think I've seen something on the chat. Please give me one moment. Thank you, Bertha. We will send a list of these resources in a follow-up email in the next few days. So a very, very big thank you to Shannon, as well as Kate and Kevin, of course, for presenting tonight. Thank you, everyone, for attending. Please don't forget to complete the short online evaluation survey, which will pop up on your screen now as soon as I end the webinar. And don't forget to visit our website to view other upcoming events. Thank you again, everyone. Good night.